5 years ago, this was me. I was happy, I was healthy, and I loved to travel. And then one day, everything changed. I got a virus, my husband also got a virus, and I had a high fever, he recovered, and I was never the same. Within months, I became too weak even to sit in a wheelchair, and I went to doctor after doctor and was told that maybe I was just stressed or depressed, and eventually that it was all in my head. I ended up confined to my bedroom without treatment, without even an explanation for my illness. And when it got to the point that I became too sick even to walk to the kitchen, I started thinking a lot, like so many others before me, about taking my own life. And I didn't. And instead I started filming myself and eventually connected to an online community of patients all around the world, many of them also confined to their homes and bedrooms. And that is the story that I tell in the film Unrest. I know many weren't able to make it last night, and so I wanted to first start by showing a clip that brings you inside of our homes and bedrooms and into an aspect of this illness that most people never get to see.
ME can be triggered by viruses and bacterial infections. But we don't know if the infection hides in places where it's hard to measure, like the brain, or if it's long gone, but leaves in its wake an autoimmune disease. I was lucky.
Hi.
My doctor prescribed me an antiviral drug called Valsite. Two days later, I was walking again.
Hello, she sees you now. Hello. She sees you.
You all right?
I'm good. I'm doing awesome.
I'm sorry, please don't. Oh, God. Ah!
Look at some magnesium.
Stop! I can't. I could feel everything in my head swelling, pushing out my eyeballs. I would try to speak, and the sounds that would come out of my mouth would be gibberish.
I can't understand, love. It's gonna pass.
I can't. So how many people know about chronic fatigue syndrome or have heard of it before? Pretty much all of us. And how many of you had an image of your mind of that disease when you think of that name? Maybe one or two people. I had never heard of this condition before I got it, and like most of us, never understood what it really was and how severe it could be. And this is a disease that has been stigmatized and as a consequence neglected for decades. And I've been spending the last 5 years living this and doing a lot of work in advocacy and also in the film I've been making, reading a lot of research. And I think the more that I learn, I've kind of wrestled with this question of why are there no treatments and why have patients been neglected for so many decades? And the more I'm in this space, the more elusive the answer to that question becomes. Because I think in reality, there is no reason. There is no reason why we haven't done more and why we couldn't do a whole lot more. I think the name matters. So the original name for this condition was myalgic encephalomyelitis. And it was renamed in the 80s, chronic fatigue syndrome. And I think the consequence of the name has been that this has become the dominant image of a disease that can, for those on the severe end of the spectrum, be as serious as this. I also think it's a deceptive condition. So the core symptom is something called post-exertional malaise, which is different from fatigue. And what it basically means, the way I describe it, is that I'm like a battery that only ever charges to a certain percent. When I was at my most severe, maybe it was 10%. Now it's about 40%. And as long as I stay within my limits, which we're starting to understand are actually like a metabolic rate limit on how our mitochondria can produce energy, if I stay within that limit and I don't ask for more energy from my cells, I can appear relatively normal. But if I go and I ask for more than I have to make, then I crash and all of my symptoms get worse. And so you can kind of see this picture of an illness where when most of us go into the doctor's office, we look like I did in the beginning of that clip when I was gardening. But you don't see us when we go home and we pay for the effort of having been out in public, of having tried to do something in our lives. And so for me, crashing is muscle weakness, inflammation, sound sensitivity, tachycardia, gut motility issues, everything gets worse. 25% of patients are homebound or bedridden, so for a large part of my illness, I wasn't even able to leave my home to go and see a doctor. And this is a patient population that until recently haven't been seen by clinicians and haven't participated in research studies. And so there's sort of this dual problem of invisibility for those of us who are well enough to still work or well enough to at least appear in public. You see us when we're well and not when we've crashed. And then there's this whole other spectrum of patients that are never seen at all. 15 to 30 million people around the world have this disease. 1 million in the US. And I think the sort of final reason why it has been so misunderstood is because we just haven't invested in research. So, it's a very common illness, and yet on a federal level, we spend about $2,500 per AIDS patient, $250 per MS patient, and until very recently, only about $5 a year per ME patient. And so when you sort of ask the question of like, why do we understand so little? People say, well, it's just really complicated, it's really complex. My answer to that question is that you can't answer the questions that you never bother asking. And for a very long time, we just haven't bothered. This is roughly a kind of graph of US funding versus disability adjusted life years. And just a different way of visualizing it, kind of fair funding given how disabling the condition is and how many people have it would be about $250 per year. And for the last many decades, we've been getting about $5 million a year in research funding, so not enough to really build a field. And you can see the consequences of that in terms of kind of rates of publication. So we're left with a situation where I would say it would stun you the number of basic questions that we've never really asked. And we need so much investment in studies of genetics. There are so many family clusters, and this definitely has a genetic component. We need research into cluster outbreaks. If you see the film, you'll see that there have been many kind of infectious outbreaks of the disease throughout history. We haven't done the kind of the basic work yet in sort of understanding the condition. But I do think that there's, one way to look at it is that we really are starting at zero in many ways. And at the same time, there's been so much advance in technology over the last 30 years that we've missed out on that I think we could catch up very quickly if we started to make those investments. So whatever you're doing, if you think you could apply that to our group of patients, we welcome you and we want you to get involved. Last night we had a Q&A and Daniel was sort of asking, like, what are some of the really basic kind of practical ways that this room might be catalyzed to help us and to help get more engaged. And as I think Andy will talk about in just a second, I think one of the major challenges we have is the lack of a biomarker. And we're having a breakout session later on today, and I would love to talk about sort of where we are. There are many people who are looking and how we can make progress more quickly. Clinical trials of existing drugs. There are so many drugs that we know help some people and not others. We don't know why, and so few people have access to them. I would not be here without a cocktail of drugs that are helping me significantly, but I'm rare in that my insurance covers them and that I live in this country. And so I want to understand how we can start doing those trials and get effective treatments of already existing drugs to patients. I think there's a huge potential for wearables and also just sort of really taking advantage of this huge online community that has been experimenting for years on themselves because they have no choice. And I want a way to have a wearable or a tracking app that helps patients understand how to stay within those limits and not crash. Patient and caregiver support, and then finally, this problem of adjacent diagnoses. So there are people who have my exact symptom presentation who have diagnoses of Lyme disease, POTS, dysautonomia, fibromyalgia, mast cell activation disorder, and Ehlers-Danlos syndrome. I think that there are reasons to believe these are all related, and also that people just have many different diagnoses because your diagnosis is often more determined by your doctor than by anything having to do with you. And so there's a lot of confusion. And how do we break through those silos and really bring together these patient communities, but also these researcher and clinician communities to get to answers faster so that we know how to match which patients with which treatments. So thank you for your time. And if you want to learn more, you can go to Unrest Film. The film is available. Also happy to send anybody a copy who asks. And you can also give me a shout out online as well. And I would love to engage and look forward to talking more. So thank you so much.
So I'm going to come at this from a little bit of a different perspective, that of the physician. I'm an infectious disease physician, Stanford trained, was at Stanford for about 8 years after my training, and ran into this condition actually somewhat serendipitously. But I actually can remember back in my medical school training, the one line in one textbook that mentioned chronic fatigue syndrome. That was my education to a world that's now consumed a lot of what we do at the Open Medicine Institute, which is looking across lots of data and lots of diseases. And ME/CFS is one of many, as Jen just alluded to, one of many sort of syndromic conditions that we lump together. There's an epidemic of chronic disease out there. More than half of Americans have some level of chronic disease, and many of them have no true proper label. ME/CFS, frankly, to me, I don't use it as a label in the clinic because it's not useful to the patient generally. But at a certain point, it gives some relief to the patient to know that they have something and that they're being taken seriously. So right now, the sort of epidemic of undiagnosed disease affects over 300 million Americans, often syndromic. Most of them have gone to see more than 20 physicians and still haven't gotten help for their problem. And they're told they're depressed and go home and exercise and so forth. And it's incredibly debilitating as a patient. And there's no diagnostic testing for these patients on the clinical front. So I'm going to tell you a little bit about what we've done otherwise. But before I do that, just to give you a sense, we ran, I'm a data guy, so I have a computer science PhD, so I'm always conflicting the clinical side of medicine with the numbers. And so some numbers on this. We ran a study across 10 million patients insurance database, US, and ME/CFS patients had a 26% increase in ER utilization, 22% increase in hospitalization, and by the way, they didn't get addressed by either of those problems, so they came back to the ER for a second visit at a 24% higher rate than the average patient. And mind you, these are patients who are showing up in the ER anyway. That's over $225 million in ER costs. So there's no, and that's forgetting all the medications, all the money that Jen and other patients have spent of their own money out of pocket to take care of themselves, because the medical system doesn't address it. So how can we look at this as another data problem or a problem of complex diseases, which I think is an area that we're starting to dive into now that we have a lot of these technologies that some of which you've heard about at this meeting. One of the problems is that data is all over the place. There's no incentive for physicians and hospitals to share data. And so part of what we've been doing in the community context is putting in place together a neutral sort of safe harbor that's not government, it's not industry. It's a place where patients can go to curate their own data, and it's protected, and they can share it to wherever they want, but at the same time, they can share it for research. And so we've engaged with a lot of different ME/CFS patients, but a lot of other cohorts as well in the undiagnosed perspective. We have an unprecedented ability, as you've heard at this meeting, to collect data of all kinds of forms. So we're now actually collecting many of the data forms and more that Jen just mentioned. So wearable data, heart rate variability data, which is incredibly abnormal in these patients. So here we now have a biometric measurement, and then all kinds of omic data, which I'll get into here. So part of our task is marrying that and applying it back into the patient, and applying it not only to their diagnosis, but to their treatment. So we're actively, we've created a UNDX program, undiagnosed disease program, of which the ME/CFS piece is a part of, to gather a lot of this data and gather cohorts. We also run a 6-year study with CDC over 6 sites looking at these patients and quantifying them in various ways. But those efforts don't go anywhere near far enough. This is an example of the first omic stab that we took at ME/CFS patients, and it doesn't take a PhD to see there's a difference in population here. The bottom green are downregulated, patients are in rows here. The group at the bottom are patients that we treated with an antiviral, for example, and they recovered. The groups at the top are patients before they were treated. Pretty different look on gene expression level. We can do proteomic surveying, and it didn't turn out that way. It didn't project well there, but there were 2 distinct peaks emerging on multiple paths of 300 proteome features, protein features. So we've got markers that are emerging there. But this is all early stage research. We're looking deeply at the microbiome. This is not modern art. Might look nice on a wall, but it's actually a patient's microbiome, and this patient took weekly microbiomes. You can see just the diversity and the amount of distortion in this picture as they progress through time. This person, their gut is not stable throughout this, and we see huge gut issues in many undiagnosed disease patients. But then you see sort of halfway through, the patient got a treatment here, and that treatment for this particular patient was actually an antifungal. And that gave them a level of stability that they hadn't had before. And we continued to work with this patient. This patient is now in Harvard Business School, and their microbiome looks even smoother. This got cut off a little bit, but we're looking at metatranscriptomics. You heard from the Viome folks earlier, and there's lots of other technologies out there. But what got cut off here on this slide, this is actually another undiagnosed patient, has, I would say, a flavor of ME. But we actually picked up rickettsia in her blood in this particular patient. So this is a tick-borne infection that there's maybe 24 diagnosed cases of this in the world, but we have a DNA and an RNA of an actual parasite that's in there that's causing a problem in this particular patient. And actually this patient also has all kinds of viral issues on top of that. So you've got 2 things colliding that in the clinical context, I, as an infectious disease doctor, if I followed the standard of care, would never have measured. And yet here, I have a new target because we looked really broadly across these patients. We take all kinds of functional measurements, diet history, and so forth, which affect, Jen will tell you happily, or unhappily probably, how much different variations in her everyday life can affect her health. Metabolomics, we can measure 1,200 metabolites. Again, it doesn't take an advanced degree to see that there's something wrong in this patient. This is a hormonal panel, and these are metabolites of the hormonal, and everything's shut off in this patient. Similarly, mitochondrial energy production, massive disruption in some of these patients. And it's different. There's different clusters that are starting to emerge here of different patient groups and appropriately different ways to diagnose them and different ways to treat them. But as Jen said, we need lots and lots more input on this and lots more controlled trials, lots more N-of-1 trials. This is another view on that data. So this was actually a cohort that we did looking at antiviral and actually also B-cell treatments. The dots here are metabolites, so we sort of scattered. The 0 point is the normal control, so we compared to about 250 normals. And you can see there's a lot of difference. So the farther out they are, the more different they are here. And we've highlighted in blue here the biggest movers on this assay. So these are the things that if you watch those dots, they'll change. So the next slide is going to show you post-treatment. And what you saw was those dots collapsed inward, which is what we want. They're collapsing back towards normal. So those are the responder patients. As Jen said, there's lots of people, patients being treated out there in the community with various treatments, and part of our challenge is to start to measure those and make sense out of those regardless of what label's been put on them. But this is a great example of why and how we can measure that, not only to start looking at a diagnostic panel, not a one test, what's your hemoglobin A1C, but an array of tests that actually starts to give us a picture of the complexity in a given patient. And I'm going to wrap it up there just to say that part of where we're going with this is looking at not only N-of-1 patients, so how can we take an individual and look at them and study them and learn something from them, and generally we're doing that in a longitudinal context. Let's take Jen early in disease, mid-range in disease, before treatment, after treatment, and so forth. And then let's scale her together, as she mentioned, with other patients who look somewhat like her, who profile somewhat like her. We will start letting the data define those clusters of patients more so than the symptoms, because that's how we're learning a lot. But obviously this pushes at a need for large data collection, lots and lots of measurements, and more broad types of measurements. So I'd love to hear from any of you, as with Jen, on how you want to collaborate around this. Funding is an issue, but technology and data is really the core of this. We've put together a very outcomes-directed program, not only around ME/CFS, but now bringing in things like autism, and we're seeing some of the same, and lots of other conditions where we're seeing some of the same perturbations that I just ran through. So I think we have a few minutes left for questions, and I think we're happy to take them.
Thanks, guys. So I love, the duo of the empowered patient connecting with, now newly empowered technology for healthcare. But for Jen, you've connected to this amazing community of CFS and ME patients out there. Have some of them brought novel solutions forward that surprised you and have actually started to make a difference?
In my specific case,
or just in general.
I think everything I'm trying I heard about from a patient. So whether it was please go see this clinician, they're doing really great work in X, or here's something, whether it's a behavioral intervention or a supplement that's really helped me. So I've tried probably 300 different interventions and have found 5 or 6 that work really well for me, which I'm happy to name. But but I think there's a lot of potential in mining that anecdotal experience, and I have basically access to a community of through my organization, about 20,000 patients, and would love, kind of to collaborate on how do you mine that, and how do you ask smart questions and structure the data people already have, which they really aren't doing anything with, to be able to also make progress and get to scale, perhaps even without a lot of funding.
So probably most of the patients in your community would be happy to be data donors. They would have to have a way to port it in.
Oh yes, they would love to be.
So any folks here with questions, comments, things they want to offer, and also come to the breakout session later? Stand up and repeat the question if you got one. Right here, shout it out. Short.
My question is that fibromyalgia and chronic fatigue syndrome, are there crossover with the chronic fatigue syndrome? And if there's a patient with a similar scenario, how do I register them with the study product?
question is, there's a crossover with fibromyalgia and others, and if they have patients, how do you register them and get them involved?
Andy will be able to offer a more intelligent question. My basic observation is that many people have dual diagnoses, and I think some people are misdiagnosed with fibromyalgia, but I also think people can have both. And I also think we have no idea what's going on.
And that's exactly the reason why we didn't frame this on one particular label. We framed it as undiagnosed disease because there is that overlap. So you're welcome to send me an email and I'll point you in the right direction.
Great. One more? Real quick.
How are we changing the way we educate our doctors? I was in school, I knew.
Had one line teaching on chronic fatigue syndrome. Are we going back and taking undiagnosed disease back into medical schools? Are we changing curriculums?
It's a question: how do we better educate medical students, doctors?
Change the way doctors are taught?
Huge issue. I think Jen's film is, and there's a couple others coming out in that same vein, will hopefully start to change the perception as a whole. But yeah, absolutely, we need more outreach into medical schools. We need to rewrite the textbooks and retrain our physicians. It's tremendous problem. I think there's lots of people looking at.
And we're doing a really big campaign and bringing the film to medical schools and to private companies and trying to kind of engage in dialogue. There's been a lot of kind of things happening at the federal level at the Institute of Medicine and at the CDC to sort of, in some ways, codify what we know now. And it just isn't getting filtered down into medical education yet. I don't know why. I don't know even what the sort of policy and kind of institutional structures are for that. But there's so much happening within the field of the people who are engaged with the disease, and the rest of the world just doesn't know about it. So, we want to disseminate more quickly, because if we do that, then doctors will have the tools that they need, and patients will get diagnosed and treated much earlier, which is, I think, what we're all aiming for.
All right, so drop up. Go see the film, unrest.film. Hashtag is time for unrest. Last 2 seconds, real quick. How do they get engaged? How do you get folks here and outside in to reach you and get involved with either of you?
Send me an email, jen@unrest.film. That's jen@unrest.film. And I would love to engage and connect and come to our breakout session at 1:45.
Andy at openmedicineinstitute.org. Happy to take your emails. Unfortunately, I can't make the breakout session.
Great. Thanks very much to Jen and Andy.
Thank you so much.